Awesome. Okay, so guys, today we'll be talking about sepsis, and it's a really important topic clinically because this is like a really dangerous situation which happens most often after infection, and it can escalate really fast to death. So it has a lot of morbidity involved, and like yeah, for medical professionals, it's a very important topic. So does anybody know the definition of sepsis or has any idea what sepsis is? Okay, so no one's gonna say anything.
Like a response to an infection.
Okay, okay, you're close. It's good. So what I'm gonna do now?
Situation.
Mm-hmm. Yeah, exactly. So you guys kind of gave me most of the words which kind of correlate to the definition of sepsis. So what I'm gonna do now, I'm gonna like put random set of words in front of you guys, and one of you or whoever's on the call can try to get the definition out of it, and then eventually I will really like give you the actual definition. So like here are the words which would come up to the definition of sepsis. So I think Josie said life threatening and Gunnar said immune response. So can you guys like formulate the definition now? And one of you can tell me.
Sepsis is a life-threatening condition in which dysregulated immune response leads to an acute organ dysfunction.
Okay, you're very close, but exactly, it's like literally that. So basically, it is an acute life threatening condition characterized by organ dysfunction due to a dysregulated immune response to infection. So there's a lot of words here, but it's very, I think the definition is very simple and given. And basically, sepsis eventually for some patients it can what happens is like some patients they have infection or something, and eventually it leads to failure in the physiological function of many organs, and eventually it can also lead to septic shock. Now the difference between sepsis and septic shock is that septic shock is a sepsis syndrome which also has circulatory and metabolic abnormalities, so it's like sepsis but just a lot worse. And if you guys want like more detail of what septic shock is, how I would define it is like it's sepsis with two major components, the circulatory and metabolic. When it comes to metabolic, it means the lactate is really high, and it's high even after you give them fluids. And the second thing, which is circulatory, is when the patient requires vasopressors so that their blood pressure can be maintained. So the best thing to remember is that septic shock is just a really horrible situation with sepsis and with circulatory and metabolic abnormalities. So, does anyone know the etiology of sepsis? I already gave it away while I was talking, so maybe you guys remember.
Infection.
Okay, infection is one of them. Anything else? Okay, if you guys don't know, that's completely fine. It's okay. So first of all, it's definitely infection, but more specifically in terms of respiratory infections, pneumonia is the most common cause of sepsis. Like 90% of the times, it's pneumonia. Then there can be abdominal infections, for example, some kind of abscess. Then it can be genitourinary, for example, pyelonephritis. Of course, skin and tissue infections, and pathogens like Gunnar said, like infection. So it can be bacterial, and most of the times it's gram-positive bacteria. And of course, other factors which can cause a more chances of getting sepsis is like age and other comorbidities, immunosuppression. And do you think I'm missing anything, or do you think we've covered everything?
I think it's covered, or maybe.
Okay. Okay, so one of the things which most people tend to forget is implants. So when you have any invasive like medical devices inside the body, or if you have an implant, so for example, even if you have like a urinary catheter or intravenous lines, they can definitely cause sepsis because I mean, eventually it's because of an infection, but the primary reason is because you have a device placed. And the second thing is like implanted devices, like in the heart or anywhere else. So they are definitely a common source of infection. So how it happens, and I think it would just make sense for me to explain it rather than asking questions, is that obviously the definition, like we said, is an acute life-threatening condition because of the immune response. So obviously the immune system is involved, and thereby there's the complement system, the mast cells, and the macrophages, which are basically trying to do their job, because sepsis, it happens due to an infection, right? So obviously we need the immune system doing its job, and while doing so it causes vessel dilation and it releases cytokines, which you must have studied in immunology. And because of that, then the endothelial disruption occurs, and the capillary basically ends up leaking, and eventually all the fluid comes out, so then there's edema. And after that, because the fluid is out, there's less fluid in the body, so then there's hypovolemia. And when there's hypovolemia, the body thinks that, oh, something's wrong, and then there's like the full coagulation cascade comes into play, and then there's disseminated intravascular coagulation, and basically the body thinks everything's messed up, and we're trying to get a hold of things by activating the extrinsic coagulation cascade, which eventually leads to decreased oxygen use and tissue ischemia. And because you're having all these thrombi everywhere, so there can be tissue ischemia all over the place, and it leads to more cellular injury. And what all of this eventually causes is multi-organ system failure, because it's not happening in one particular part of the body, it's happening everywhere. So all the organ systems start to fail. So what do you think the clinical features are of sepsis? It's like super easy. Like if you have an infection, what do you think the clinical features are going to be?
Like higher heart rate and low blood pressure,
Okay, higher heart rate. Anything else?
fever,
Yes, fever. One more.
Extreme pain, also like confusion or disorientation.
Okay, yes, you can have extreme confusion. Yes, but that is much later. In the beginning, what do you think are the three main clinical features? You guys covered most of it, but I'll just tell you. So there's
Nausea.
fever. Sorry.
Nausea, like vomiting.
Nausea, vomiting can occur, but it's not necessarily. It's not one of the main features. So there's definitely fever.
Skin color changes.
Skin color that's what it happens later. In the beginning, we have fever. There's tachycardia, like she said, high heart rate, and there's tachypnea. These three are the main clinical features you will see in the beginning. Also, you'll have organ dysfunction. So there's the three C's, which are the ones you should remember: CNS impairment, like you said, confusion, etc. Cardiovascular failure, hypotension, and coagulopathy, which I mentioned in the previous slide. And obviously there's liver failure, kidney failure, respiratory failure. That is because eventually sepsis is causing multi-organ failure, so you will end up seeing all the organ systems failing. So how do we diagnose it? Does anyone know how we can diagnose it?
blood culture test.
Sorry, I didn't hear you. Okay, so
Sorry, it's the to take like blood pressure.
okay, but like you mean blood culture, or did you say blood pressure?
Oh yeah, I said blood culture at first.
Okay, blood culture. Anything else?
Temperature, heart rate.
Okay, yeah, those are the preliminary ones.
To look at the mental status.
Okay, so basically, so you guys have covered like the ones that I'm going to talk about, and there's a few more. So basically, there's labs which we need to do, which is serum, lactate, and blood cultures. Because when you do lactate, you can find out specifically if it's going to end up leading to septic shock, and also you can find out whether it's bacterial origin or something else. Blood cultures the same. You can figure out into more detail as to which bacteria it is. Then complete blood count, which will give away if there's leukocytosis or thrombocytopenia, because those are like the main signs that the person could be going into sepsis. CRP, procalcitonin, these are definitely important. And can anyone tell me why we check procalcitonin? Like, do you guys have any idea? Because the others, we always talk about it in the hospital, but like procalcitonin really helps in terms of sepsis. So does anyone know why it's important? If not, I'll tell you. But if you guys had to give a wild guess, like, what do you think it is?
Isn't it like a biomarker for the antibiotic or something?
Okay, it is a biomarker, you're right, but it's a biomarker specifically to diagnose sepsis because it's involved in the calcium hemostasis. So when the body is undergoing some kind of infection, the procalcitonin rates just increase. So it's a proper biomarker for sepsis. So yeah, it is a biomarker. So good. Then, of course, the electrolytes, we have to check the renal function, the BUN and the creatinine, they get increased. There's hyperglycemia. There's increased INR. Does anyone know what INR is? Or what it signifies?
Hasn't it something to do with the like?
Yeah, it's to do with coagulation. Exactly. Yeah. So it's a prothrombin time. It's like the international normalized ratio or something like that. And it's basically a ratio for the prothrombin time. Just check your clotting, basically. And because I mentioned in the mechanism of sepsis that the clotting goes bizarre, right? Because the body thinks that there's some bleeding going on or something's not okay with the vessel. So there's just unnecessary amount of coagulation cascades being activated. So the INR is a good diagnosing factor. And then we have prothrombin time and D dimers. And of course, we need to find the source of the infection. So, for example, I said if there is a device that's implanted, or if you're using a urinary catheter, you need to know like that is the reason why this is happening. And if it's a urinary catheter, you need to remove it as soon as possible. So, one of the really important concepts which I specifically came across during intensive care was SOFA and QSOFA. I actually did not know about this until intensive care. So basically, there is a difference between these two concepts. So for SOFA is sequential organ failure assessment, and it's a score which is used in critical care settings to identify organ failure and obviously to predict mortality. One thing to really keep in mind is that it does not help you diagnose sepsis. It just helps in figuring out what is the current status of the body and which organ system is working in what manner. So it's like an elaborate scoring system which involves all the systems. So respiratory, cardiovascular, coagulation, liver, CNS, renal function, so everything. But it doesn't necessarily diagnose sepsis. It just tells us whether or not an organ system is working properly and to what extent. For specifically CNS, I remember Josie saying mental confusion. Do you know any scoring system for the CNS which we could use in SOFA? I feel like we have talked about it in classes, so maybe either of you, if you know it, what do you think it is?
I actually have no idea.
Yeah, no idea. Okay, it's fine. It's okay. But Gunnar, do you know? I'm pretty sure when I say it, you guys are like, oh yeah, we've heard of that. But like, do you guys have any idea?
Something simple, but I can't think of.
Okay, no problem. It's fine. Don't worry about it. I'm just trying to like, get your minds working. But basically, it's the Glasgow Coma Scale. Now, this table here is, yeah. So you guys must have obviously heard of it. So the Glasgow Coma Scale is what is used in the SOFA score. So the SOFA score obviously has its different components, but for the CNS, they borrow the Glasgow Coma system. So they don't have their own thing. And And this table right here is what exactly the SOFA score system looks like. So there's obviously the respiratory function, coagulation, liver, which is concentrating on bilirubin, cardiovascular, which is hypotension, CNS, like I said, and renal, which, so basically all the labs that we basically mentioned in the previous slide, but in a more organized manner and in relation to other organ systems, so that you can classify the patient in a SOFA score. Now, QSOFA is relatively a little easier to use, and that's why it's called quick SOFA. And it's more bedside, and it is for people who have a suspected infection, but they are not sure whether or not the person would go into sepsis. So it just makes sense to look at 3 criteria rather than looking at this elaborate table over here for SOFA. So the 3 criteria here is low blood pressure, high respiratory rate, and altered like mental status. And over here, if you want to have a positive QSOFA score, first of all, the patient has to have an infection. And secondly, out of these 3 criteria, 2 of them have to be satisfied. So 2 or more. So like over here, you can see it says not high risk, continue management as appropriate if there's 0 or 1 point. But if it's 2 or 3 points, then definitely there's high risk, and you should further go into doing SOFA and checking the other organ systems and making sure that there is no dysfunction whatsoever. So that's that. Do you guys have any questions until now?
No, until now for me everything is perfect. Thank you.
Yeah. Okay.
Yeah, it's
So,
good.
okay. So now acute management. Obviously, now we know how to diagnose. Now we know what tests to do, which scores to use. So how do we diagnose? How do we manage the sepsis? Early recognition is key. So definitely, if you think someone is going further from an infection into sepsis or something, just do QSOFA. Just use QSOFA and try to figure out whether or not the person is having organ dysfunction. Then, if you think it is, then start with antibiotics, broad spectrum, within 1 hour. Fluids, definitely the person needs fluids because they are having hypovolemia. So it would be best to just give some kind of crystalloid infusion. Oxygen definitely would be required because oxygen levels are also decreasing. Now, if there is some kind of traumatic situation which would have caused some kind of wound injury or something like that, then you would have to call a surgeon and get some surgical involvement. And then obviously to review the whole thing, which is critical care review. Now, these tables here, I picked the one on the left side from some first aid website. And the second one is from the Oxford Clinical Medicine book, which is the one I use usually. So both of them cover more or less what you're supposed to do in an emergency setting or in an acute setting when there's sepsis involved. And it's basically what I said here, but it's more detailed. So you guys can definitely have a look. I think once the presentation is uploaded, you guys can have a look at this. But it basically is what we learn in intensive care and covers mostly the things I already mentioned. So that's my take on sepsis. You guys don't have any questions? Then we can move on to case study. So do you guys have any questions?
No, it's fine for me.
No,
Okay.
it's also fine for me.
Okay, so now I have like a small case study prepared, and it's not gonna take too long, don't worry, and it's super simple, and it's just for me to make sure that you guys listened to at least 1% of what I said. So here. So we have patient X, who is 78-year-old male. He's retired. He used to work in an oil and gas company, and he was married. He's married, and he lives with his wife. He has a history of hypertension and atrial fibrillation. So he arrived to the hospital with hematuria, which is blood in the urine, confusion, and altered level of consciousness. He was at a basketball game with his wife, and his behavior seemed a bit drunk. And so when he went to the washroom to urinate, he saw that there was blood in his urine. So his wife decided to call the ambulance. Now, physical exam. So in the physical exam, the vital signs were, as you can see over here, So can anyone tell me if the vital signs are okay, or do we need to, like, I don't know, concentrate on one particular vital sign?
Like, I feel like most of the vital sign is like kind of good. Maybe.
Okay. Yeah,
Yeah.
you're right. It's fine. Everything looks good. The BP is fine. We spoke about hypotension. We can't see any hypotension. We can't see any fever. Maybe a little bit of fever, but not too much. His heart rate looks okay. His respiratory is fine. His pulse O2 is fine. So okay, great. But what else they ended up noticing was irregular heart rhythm, dyspnea upon exertion, motion generalized weakness, slight fever, like I said. So I was gonna ask what should we do next, but I clicked too fast. So definitely you guys already saw it. So we need to do labs, right? So what do you think would have come up on the labs? Or what are we looking for in the labs if we want to look for something suspicious?
For the C-reactive protein and the procalcitonin,
Okay. Anything else?
the INR.
Okay. Anything else? Okay. So CRP definitely, procalcitonin definitely. So his CRP levels were high. His procalcitonin levels were also high. His white blood cell count was high. And upon further urine analysis, he had high nitrates, high protein, high occult blood bacteria. He had basically everything high. And then they found out that he had had a long, prolonged UTI, like for a really long time, and he hadn't got it checked, which would have led to sepsis if he hadn't arrived earlier to the hospital. So, and also he didn't have any pain, but he had bright red blood in the urine. So, what do we do now? What's the next step?
Is there any diagnostic imaging that we can do?
No, because the labs were so we are this patient has come in an emergency setting, so we cannot do labs.
So
I mean,
there's
we cannot do any imaging. Sorry, we have done labs. What do you think we should do as soon as we have received labs?
I guess start him on treatment.
Yes. So, what kind of treatment?
First of all, antibiotics.
Okay, and what antibiotics specifically do you think we should start with? Because we don't know the bacteria yet.
broad spectrum antibiotics.
Broad spectrum. Do you have any example in mind?
Ceftriaxone.
Yes, ceftriaxone. Perfect. Anything else we should start?
Maybe give some fluids.
Okay, perfect. So fluids. Anything else? Okay, it's fine. If you guys don't know, that's perfectly fine. These two are the main things we need to start with. Apart, and we should definitely give. We would have given him oxygen, but his oxygen levels were fine, so we don't need to give him oxygen. So, upon further assessment, the doctors also gave vasopressors and corticosteroids because he had some kind of edema. So, but the first two things you should start with is definitely antibiotics and fluids. So, good job, you guys got that. And so they treated him with this combination, and then he was kept in the hospital for 3 days, and he was discharged, and he was fine. So yeah, that's it, guys.